Good morning. Welcome to MEDIC's August collaborative meeting. This is Keith Coker in the Coordinating Center. And I just want to reset a little bit about where we are with things for those keeping score. We haven't had a collaborative meeting since 2019. The March meeting we had to cancel because of COVID. Those were the early days of the pandemic. We then postponed the June meeting, which we had planned to have in person in Grand Rapids, and set it up for obviously today, and had to switch to a virtual format. So this is certainly a bit of an experiment for us as a team. We want to hear your feedback about how this webinar live streaming event works. We are in a studio. But it's a large studio, and we are taking all the precautions. We are wearing masks off camera, and we are social distancing. We have a great agenda for today. We have an awesome outside speaker, Dr. Jeff Kline. So certainly stay tuned. We're going to start things off with Michelle Nypaver. So Michelle, I'm going to hand things off to you.
Thanks, Keith. So I'm going to take you through a few things just for hospitality, just to remind everybody. Keith has a SAMHSA State Opioid Resource Grant to disclose. The rest of the team, myself, Andy, Carrie, Jason, and Michelle Macy have nothing to disclose. Really want to get excited about our new recruits. MEDIC is getting bigger. We have an overall strategy to get to 50 by 2024, and we're meeting that goal. Welcome to St. Mary Mercy Hospital in Livonia. Henry Ford is really increasing their footprint. They've added Macomb. They've combined two of their sites, Wyandotte and Brownstown, into one site. West Bloomfield is joining the Henry Ford group as well. Mercy Health in St. Mary's in Grand Rapids is newly aboard. We have one site that has paused their membership due to COVID. That's at Hurley. But right now we're at 23 sites and growing. So we're excited to move forward with you. So we want to, again, recognize our newest team member, Carrie Smith. She's going to tell you a little bit about herself. She's the clinical info analyst for the MEDIC program. She largely works with the data abstractors and does a fabulous job with connecting with them and to make sure that the data that you submit is as accurate as possible, which then turns into our performance measures. So she has a tall job. So the agenda today in front of you, you should have been sent that in your materials via email. This little brief moment is to just tell you a little bit about where we are with MEDIC. This will be followed by Andy Scott taking a deep dive into our overall 2020 P4P strategy, as well as our guest speaker, Dr. Jeff Kline, who will be joining us at 10. So we're doing things a little bit differently because of the virtual format, and we want to make sure everybody is aware of that. Specifically, in past Zoom meetings, we had you use the chat function, and today we are not going to do that. So to ask a question or share a comment at the bottom of your screen, you're going to text, I should say type into the Q&A box your question. Megan is sitting off camera. She's going to collate those questions as they come in, and we're going to be able to tackle those. So it's going to be very important for you to recognize that, and we truly want your input, so please, by all means, you are welcome to do so. And just remember, the time is going to be allotted after every section we go through on our agenda, so that you'll have time to discuss or get your question formatted and asked. If by chance we can't get to your question, we promise we will follow up with you after the meeting if there's a section that causes more questions than we expect, but we will get to you. So don't forget, we offer CME credit for those who are new, in this case 2.5 AMA PRA Category 1s. But remember, these expire after 6 months. There's a QR code here that's been sent to you in your slide deck, so you should be able to connect and get those. We really, really want to tell everyone that your survey, your feedback is very important. So please understand that you will be emailed a survey after this meeting, probably within 24 hours. So look for that in your email and want to make sure that you do give us some feedback so we can improve. It's very important to both us as well as Blue Cross Blue Shield to make sure that we're serving you as best we can. So we want to give a big shout out to, as Medic grows and becomes more impactful, we're beginning to get onto the national stage with our work. The JAMA Health Forum highlighted a piece by both Keith Coker and Michelle Macy recently, as well in the emergency department patients in the early months of the coronavirus disease 2019 pandemic. What have we learned? It was an excellent piece if you haven't caught it. For those who haven't heard, the academic emergency medicine publication by Keith and our team regarding the CT scan utilization for pediatric minor head injury in the emergency department, a quality improvement initiative, that was just submitted by Raj Arora. I'm sorry, I was referencing Keith's other academic emergency, or annals piece, rather than this one. So Raj, shout out to you and your team. And just this week, we've submitted to a pediatrics journal our chest x-ray work. And again, the pediatric committee members have been instrumental in that work, and we thank you for that. So again, CME credit for the Medic COVID grand rounds is still available. We want to make sure that everybody understands that your input and your time spent on the COVID work is really very important. So take credit for that. So we're going to go over a little bit about the past 6 months. As Keith highlighted, you know, all of us were dramatically impacted by COVID, and we're going to show you just how that impacted the overall data registry. This is a slide that depicts the Medic ED weekly volume from January 1st, 2020 to June 30th, 2020. And you can see the significant dip in weekly case volumes. This is the collaborative as a whole. So this isn't one site, this is all of us, really largely between the March period when COVID really kicked off till likely the first week of June. We all took a major deep dive in our overall volumes. In terms of the abstraction work, remember some of us, unfortunately, were redeployed, our abstractors during this work to try to make sure that although Medic, the registry is only as good as the data submitted, so some of the abstraction was affected by that as well. So again, the volume by abstraction from January 1st to June 30th by the case cohort of the quality measures that we are currently working on. You can see the differences here from the chest pain, head injury, PE, and the pediatric respiratory. The abstraction process was significantly impacted. Similarly, when you look at year-over-year comparisons from 2019 to 2020, you can see the significant change in 2020 monthly ED volume. So by specific quality measure, when you look at the weekly numbers of adult head injury cases in the cohort, all of the quality measures I'm about to discuss, including the adult head injury measures, were all deeply impacted in this year, but have almost recovered to their pre-pandemic levels. So you can see that with the PE cases a little bit closer now as we hit into the end of June, which is the end point for these slides. The pediatric respiratory cases, again, still a bit of a gap. So clearly the pandemic was a significant force and impact on the data registry, and we're going to talk a little bit about that impact and how we're going to interpret and score Medic moving forward. But I want to just give you a visual highlight of what happened. Similarly, at each of our collaborative meetings, we also talk about our performance over the previous segment of time since our last collaborative-wide meeting. So this is our Medic Quality Initiatives dashboard and looks at each of our quality measures. And you can see that the adult head injury measure, which is supposed to be trending up, is trending down just a little bit when you look at it, comparison from 2019 to 2020. But remember, the data is really from January to March as we've paused the data after March, likely due to the pandemic. But you can see that pediatric minor head injury, which is supposed to be trending down, had a significant trend up. The pediatric minor head injury, intermediate use versus overuse, again, significantly trending up when down is better. The adult CT for PE, pretty on point, hasn't really changed, which is an interesting finding. And then pediatric respiratory illness, again, trending, the normal trend would be expected would be down, but is trending up. So I'm setting ourselves up for some discussion about taking a deeper dive as Medic moves forward into 2021 and really focusing our attention on CT use for head injury. So the Medic VBR report, remember our goal as a collaborative, as a team, is to perform in the green segment of this chart. So this is the report for the percent CT scans for appropriateness for the adult head injury measure. And you can see up until February of 2020, we were moving in the right direction. Similarly, for the CT injury overuse for the pediatric component, we were also trending in the correct direction to get VBR in the green segment. For the intermediate CT use for the children head injury, we are slightly trending in the wrong direction for VBR and that measure. So I'm happy to take questions about this. Again, these slides were depicting up until the COVID pandemic really hit in March, and we're going to talk further in this collaborative-wide meeting about that, but I'll take questions now if anyone has them. Okay, then I'm going to hand off, if there's no questions from Megan, I'm going to hand off to Andy Scott, our project manager, to take us through the next point of this collaborative-wide meeting, the 2020 P4P grading and the 2021 proposed P4P grading.
All right, thanks, Michelle. Hi, everyone. For those who I think I've met pretty much everyone at this point, my name is Andy Scott, and really what I'm going to try to talk to you the most about now is the grading, the pay for performance grading for 2020 and for 2021. I know that we've got a lot of questions of what does all this COVID stuff mean for us for our grading for 2020 in particular. So we spent a good amount of time in the coordinating center trying to think through what was fair, what made sense. Blue Cross has been really accommodating and giving us the leeway to say, what do you guys think makes sense? How do you think that we can do this in a fair way that doesn't off top line, the guidance from Blue Cross is don't punish people for COVID, but in any way that's possible, try to keep some focus on the actual QI work when it's appropriate and when it works. So. That's kind of the context of what we looked at, and so I'll start with 2020. So that's our current year, remembering that the time frame for that starts November 1st of 2019 through October 31st of 2020. So we're 2/3 to 3/4 of the way through this time period at the moment. So first thing, for participation for the COVID period, which we're defining as March 1st through June 30th. So the start date, a week or two before all the lockdowns started here in Michigan, and up through the June 30th date, where Blue Cross kind of gave the guidance that all abstractors and all work should be back on the CQI work. So we kind of defined those 4 months as our COVID period. So nothing will be graded for participation during that COVID period. So no penalties for late abstraction, no penalties for late data transfers. We didn't have, obviously, as Keith talked about, we didn't have the March collaborative meeting. I think we did have an executive committee meeting and some, clinical champion stuff. We did not, certainly, and Carrie's obviously been really engaged with the abstractors through this whole time. We did not take formal attendance for any sort of grading or penalties or points for that period. And then for the sites that were kind of in progress of onboarding, part of the points for a new site would be, hiring an abstractor or initiating your data transfer within the first 90 days after your participation agreement is signed. Essentially, when March 1st came, those clocks stopped, and then they restarted on July 1st. So really felt like from a participation standpoint, it wasn't realistic to expect that really to hold anyone to those standards during those 4 months. So none of that will be considered for the 2020 P4P. for the performance was harder. So we kind of had to figure out how do we take this, kind of diverse state of Michigan with, a very uneven hit from COVID in, Southeast Michigan got hit with much harder cases or many more cases, whereas the whole state was really prepared for that and it didn't end up happening everywhere. So trying to figure out, how do you account for that? And then, some of the clinical questions we got were, if we're ordering more CTs, chest CTs, or chest X-rays around suspected diagnosis of COVID, does that mess with the numbers? So we really, we tried to run all the numbers with, for the whole year and then without that time period, and found that the effect of either one of those two kind of methodologies was really uneven, and it was really hard to say which one was better. Some were better for some sites, some were better for others. So and a lot of that was, probably all of that was really realistically out of the control of the sites themselves. So what we settled on was that essentially we're going to, when the year comes to an end, when we have your data through October, which is the end of the 2020 P4P year, we'll calculate, for every quality measure that you're working on, we'll calculate 2 scores. The first one will be as if none of this ever happened. We'll take all the data you have for 2020, November 1st, 2019 through October 31st, 2020, see where you fall in regards to the targets. The second thing we'll do is take the 8 months that were, knock on wood, that we don't go back into any kind of high level COVID time, but between now and November. But we'll take the 8 months that were not part of that, the 4-month COVID period, and calculate your score without those 4 months. So the one thing we will try to do, which is still a little bit of a work in progress, is to look back at the actual targets that we set, specifically with some of the conditions that might have some seasonality, to figure out if the targets themselves need to change a little bit. We want to really make sure that we're doing an apples to apples comparison. So it's important to relook at those targets. So bottom line, we will take these 2 scores, 1 score as if none of this happened, 1 score without this 4-month COVID period, measure them all, and then you'll get your best score from the 2. So this is not something you need to actively choose. You don't have to say we want this or that. We just have to, we will do that for you and feed that information back to you. So we are hoping or aiming, maybe more accurately, to have a little bit of a, we haven't been sending the regular monthly report, so we're hoping to have a monthly report sent out to you in early September that will show where you stand with each of these 2 grading systems. So this is labor intensive. This is not, we'll have to site by site go through and do this. So it's not something, we can just click a button and have these numbers. So, we will try to run those scores and get that information to you as quickly as possible. So, the broad take homes, I guess, for the 2020 P4P grading: 1, participation, don't worry about it, March through June. We are really happy that a lot of you were able to keep with it, but I know that several abstracts were redeployed. Clinicians obviously had their focus in other areas. So, participation, don't worry about during those times. And for the actual performance, we're going to calculate 2 scores, 1 with the COVID time and 1 without, and you'll get your best score for the 2 of those. So that's kind of the take home for the 2020 P4P grading. I'm going to go kind of through the 2021 proposal now really quick. This is something that still needs to be approved by Blue Cross. We had a great discussion with our executive committee this morning to kind of hone in on some of these things. So for 2021, we put together the proposal that we'll be sending over to Blue Cross. So the first thing to look at for year 1 sites, so these are sites that sign their participation agreements and start working in 2021. So a lot of these sites may not even be on, but the main thing that a new site will have to do in year 1, this wasn't in the 2020, but I just want to kind of highlight, is that you need to, besides signing all your agreements, getting your data transferred, getting your abstractor hired, is to start planning for the actual QI work in your year 2. So at the end of the year, we'll be asking for a intervention template to start your QI planning. So this, like I said, this was in the 2020 P for P, so sites that are new in 2020, like Michelle mentioned earlier, St. Mary's in Livonia, the 3 new Henry Ford sites. You'll be looking at the end of this year to submit your intervention planning for the QI work for 2021. For year 2 sites, now these will all apply to year 2 and to year 3. So year 2 and year 3 sites are going to be working on site-specific safe discharge goals. So our 2 pediatric centers, Children's Hospital of Michigan in Detroit and DeVos over in Grand Rapids, will be working on safe discharge for asthma, and all of our other hospitals will be working on safe discharge for low-risk chest pain. And then those are site-specific goals where you'll be working towards a target. And we do have, since these are kind of the continuation of the path or the alternatives to hospitalization models that we've had in the past. And there's kind of 2 levels to getting these points. One is doing the actual work, doing the narrative reports and implementing some sort of countermeasure, and then the actual performance of whether you increase or actually do better or meet the targets. The other things that we have for year 2 and year 3, there will be collaborative wide measures for head injury for adults and for pediatrics. So, this is something you'll probably hear more over the next year, but, we're kind of, especially with complications from the COVID with chest x-ray and PE, really just want to think about 2021 as an, like I said, we'll say this over and over, an all in for head injury year. So, we've been working on these head injury initiatives for a couple of years here in Medic. Have made nice progress, but really are hoping that the next step will be to kind of push those all the way up so we can really achieve the goals that we're looking for there, and then that we will be able to move on to the next things. So there'll be collaborative wide measures for adult and pediatric head injury for the year 2 and year 3 sites. The other change that is coming into effect for years 2 and year 3 is that this will affect the abstractors, and I think Carrie talked about this a little bit this morning, is that we've traditionally given either 5 or 10 points, depending on what year you're in, for the data accuracy of the abstraction. So that's previously just been a percentage of all the data elements that you abstract and giving you a score on that. As Carrie's kind of dove into it a little bit, what she's seeing is that we really want to make sure that we're focusing on making sure the cases are in the right cohort. So we've split out those points, and so now that whether it's 5 or 10, 40% of those points will be based on getting the cases in the right cohorts, and then the other 60% will be based on the actual data element accuracy, similarly to how April did it in the past and how Carrie has done it this year. Okay, so for year 3, so essentially everything that I talked about for year 1 and year 2 also applies to year 3, the 3 and above. So this is the majority of our sites, to be honest. So again, we have the all-in for head injury, collaborative wide goals, and site-specific goals for the year 3+ sites. So, the way that we generally set these targets, and we'll get the actual numbers out to you, will be that the collaborative wide goal will be a little bit of a lower goal that everyone will work to together in kind of a team sport type way, and then the site specific targets will be set a little more of a stretch to get each site to push themselves up to the higher performance. Then the other things that we're doing, so this is a little bit of a change, and we'll send out email communication about this too, but the whole idea, there was concern that, like I've talked about before, that the PE and chest x-ray work was potentially compromised by COVID and some of the diagnostic decisions that the clinicians are making. So we are moving both those measures into a temporary maintenance period for 2021. So, we will still, are planning to produce, we've sent out the PE materials, we've mailed that and given it to you digitally to help support your QI work in the hospital. And we will really not take our eyes off of that and continue to work to help you guys work on that, but the grading will be a little relaxed for 2021 as we kind of fully understand the impact of COVID on this. So everyone will need to maintain within 10% of the previous targets for PE and chest x-ray. And then finally, CT overuse for kids is a measure that medics have been working on, I think, since the start of, since we started working and grading but on quality initiatives. And it's one that we've done really well on. The performance from the collaborative has been really good. We have several sites whose overuse numbers are, in the low single-digit percentages, doing really well on this. So this is a measure that we are kind of in its, end of life cycle type phase where we expect that everyone will maintain to the performance target set for 2020 with the idea that if we kind of feel like this work has become routine, well, routine's maybe not the right word, but this has become kind of established practice within the sites, and this is where everyone is comfortable being, and it's a reliable and maintained measure, then that measure will kind of transition off of our P4P in our focus for the years to come. So a lot there. I think that we've fielded a lot of questions around the 2020 specifically, like how are things going to affect, how is the COVID and the redeployment of abstractors going to affect the 2020 grading. So hopefully kind of laid that out there, and I want to now open it up for questions and see if we have any. Megan is shaking. No questions? Okay. Maybe I'll give another 10 seconds. Anyone feel, again, we are, I know that this, and feel free to email as well. I know that that was probably quick, and we'll send this material out afterwards, but we want to make sure everyone really feels comfortable understanding how the grading will work for 2021. Okay, so with that, I will turn it back over to Keith, and he will give an introduction for our guest speaker. Thanks.
All right, I'm back. So I have the pleasure of introducing our guest speaker, Dr. Jeff Kline. He is an emergency physician and the Eskenazi Foundation Professor and Vice Chair for Research at the University of Indiana. He is also the Editor-in-Chief of Academic Emergency Medicine, really one of our major specialty journals. And most of us, I think, who are emergency physicians think of him as, the authority on all things pulmonary embolism. For those that don't know his work, he was the leading drive behind the development of the PERC rule. So please lean in on this one and welcome Dr. Kline. Actually, one statement I want to make before we get started. So we are going to have time for questions. We're going to reserve those until the end. So put those into the Q&A box, and we will collate those in the background and circle back to those at the end of the talk. All right, take it away, Jeff.
All right, thank you, Keith. It's my pleasure to be here and get to talk to the collaborative. So here are my disclosures. I'll point to the first disclosure because I am going to talk about some research that I've done that was funded by Janssen and Pfizer. You can see the rest of my disclosures here. What I'd like to do is I would like to go from relatively dogmatic down to just sort of pure research. I'm a researcher, so if you ask me to talk, you're going to get some of my research that I'm involved in. But what I hope to do is to talk about some pragmatic issues that probably most everyone knows about, but just to maybe update on where we are with clinical practice guidelines and really talking about what is now reasonable and prudent to say is medicine. It is 1A and ready to use, and then go down to some more speculative and what I would call fun thinking that hopefully will generate some discussion. So let me just start with an overview of a typical management algorithm when it comes to diagnosis and exclusion of pulmonary embolism. And typically most of these will start with some type of pretest probability or sort of out of the primordial soup of our decision making, a way of organizing the probability of pulmonary embolism. And I think there are lots of validated ways. I'll re-emphasize again and again that Gestalt, just asking the question, do I think it's low pretest probability is as good as, maybe better than a Wells or simplified revised Geneva score. That simplified revised Geneva score always raises a little confusion because there was the Geneva score, then there was the revised one, and then there was the simplified revised one. And I'll give a little pointer. The Wells score and the simplified revised Geneva score basically are scored the same way when it comes to ordering D-dimer. If either are below 5, then you're good for a D-dimer. If they're in the low probability zone where you ask yourself the question, do I think PE is unlikely? Do I think this patient does not have PE? You're good to use the PERC rule and then move through a quantitative D-dimer. I'm going to strongly emphasize that age adjusting is ready for prime time. And then over here is the imaging side, which is, I see, an important part of the collaborative. And I'll talk a little bit about imaging, but mostly just about getting started. And here's a reminder of what the PERC rule is. It asks the doctor or advanced practitioner to say, do I have a low gestalt suspicion? And that's just, it requires you to get your own attention and think about the patient in the patient's entirety, and then make sure they have these 8 criteria. And if they're all negative, then this reliably predicts a probability of pulmonary embolism that's less than 2%. And that's with 45-day outcome, which is similar to what you find with a negative CT scan or a negative D-dimer. And there was a controversy that existed for about the last decade that it worked well in US populations, but there were questions raised about whether or not this would even work in Europe because they have such a higher prevalence of disease. So that set up the need for a European management study where PERC rule was used or not used. And Jonathan Freund did it in this thing he called the proper study in France, where France, they typically will have prevalences of PE on their CT scans of 20 to 25%, even as high as 30%. And that's all. The Medic-wide collaborative has a prevalence of around 9%, which I'll hold out as extraordinarily high in the United States. But because of that concern, people weren't sure whether or not PERC rule would work in Europe. So with this management study, Jonathan randomized hospitals to either use the PERC or not, and he did so in a scientifically rigorous fashion where he made efforts to be sure they weren't already using PERC when they were using the wild type method. He enrolled 1,900 patients, and everybody in this study had to have a Gestalt low pretest probability using French Gestalt, which turns out French Gestalt works as well as American Gestalt because the PE rate in the whole population was under 3%, which is what we found reliably in the United States when we asked you, do you think this patient has a low pretest probability? That population will have an outcome rate of around 3%. So it worked well in terms of just asking Gestalt. That's an important finding from this JAMA paper. And what they found in the PERC group was only a 0.1 or one single patient had a false negative PE, and that person had a subsegmental PE that did ultimately get treated, raising the controversy of whether or not subsegmentals need to get treated. In the non-PERC group, there were lots more subsegmentals that ended up getting anticoagulation. And CTPA was significantly reduced with PERC by an absolute number of 8%, which was pretty good. So overall, that led to an adoption by the latest clinical practice guidelines that I know of. If there are others, I've missed them. Maybe NICE has some out. I know ATS does not yet, but is planning. And these were the American Society of Hematology clinical practice guidelines, which actually did not cover pretest probability scoring criteria, but recommended PERC nonetheless. And there's some of the exact language. American College of Physicians recommended PERC as a best practice advice, and ACEP gave it a level 2B several years ago, and I believe there are new PE practice guidelines coming out from ACEP soon. PERC was a choose widely recommendation. So just a reminder, this is a reasonable and prudent thing to do. In terms of my own research, I'm turning to PERC in children and have a large project through PCARN where we're testing something we call PERC Peds, which will be the same except we'll have a age-adjusted heart rate. So that's upcoming. So I think this is some relevance to the collaborative, and that's the long known fact that young women are over-tested, but yet are at the biggest risk for low value CT scanning, primarily because of the risk of breast cancer. There's really no reason that women should be getting tested more. They have the same rate of PE, but in the emergency department, they comprise up to two-thirds of patients receiving CTPA, and typically a higher number who receive low-value CTs, meaning those with very low outcome probabilities, like in the 2 to 3% range. And this is something that I think that this raises controversy because a lot of emergency physicians don't want to think about it. But these are 6 fairly large registries done in 6 different countries that basically tell us that for every 10,000 CTPA scans performed on women less than 40, about 35 as a direct result of that single CT scan are going to develop cancer in one of these organs. So whether you choose to believe this or whether you don't, this evidence is out there, and it could come back to haunt us as population scientists look more at low-value CT scanning, particularly in women. Along those lines, we did some work in 26 hospitals, including in the Indiana area and in the Indiana state, using the IU Health system, and also the Baylor Scott and White system down in Dallas. And what the main question was about whether there was a difference in these two systems. Now, the Baylor Scott and White system had implemented a specific quality improvement program similar to what the collaborative has done. And that's to go in and teach emergency physicians to use the PERC rule and D-dimer liberally or more efficiently. And then did follow-up to show each doctor how each doctor was doing relative to their peers. Those are the blue squares, and then the black circles are Indiana, my own health system, that did not do any such teaching. So we have 27 hospitals in this. And the point of this regression analysis is each dot is a hospital, and the more D-dimer use, the higher the PE yield rate. Now, this is just correlation, it's not proof. One thing I thought about was I wrote this paper and it published in January. Boy, I didn't expect what the byline of this title would mean coming up, the continuing epidemic. I don't know if that was prescient or not, but man, we've had an epidemic. So that raises the question, people, they kind of resist using the D-dimer. They know there's a high false positive rate for all the reasons shown over here in these bullets. One that really particularly vexes emergency physicians is pregnancy, and this scatter plot shows D-dimer concentrations as we move forward in later pregnancy. Out in the 3rd trimester, almost all the dots are above the threshold for an abnormal D-dimer, shown in that dotted horizontal line down there. So some kind of an adjustment is necessary if you're even going to try to use a D-dimer in the 3rd trimester of pregnancy, for example. And you can see a similar plot, it might be in reverse post-operatively or in patients with cancer undergoing treatment. Most of the dimers are above threshold. Age naturally increases the D-dimer. It's unfair, but there's more inflammation and our bodies fall apart. And the immune system is connected to the coagulation system. And as we get older, we have more reactivity and higher D-dimers. That led to the biological basis for age adjusting the D-dimer, and simply stated, age times 10 for patients over 50, that's a reasonable standard of care. It's received a strong recommendation, a level 1A from the ASH guidelines. And I just want to hold this out again, that if you're not doing age adjustment and not promulgating it, well, you probably should be giving a good explanation of why not, because it is a level 1A and it is ready for prime time. And this is just some data from the ASH guidelines showing the overall performance of the D-dimer. For example, just look at the top part of the red box, sensitivity 97, specificity 39. If we age adjust, the sensitivity stays the same, essentially. It certainly doesn't increase. I would just say those are within confidence intervals. And we got an almost 10% increase in specificity. So that's the benefit and should be used. Now, there are other threshold adjustments, and I want to talk for a minute about pregnancy because this is a question that comes up in virtually any PE talk. And we now have 2 management studies that tell us that we can use the D-dimer in pregnancy. In a clinical practice guideline published about 8 or 10 years ago by the American Thoracic Society, they actually cited that they didn't think the D-dimer was warranted or didn't believe that it was safe. And now we have evidence that, in fact, it is. There are different ways to cut the threshold off, but probably the simplest is just to double the standard threshold for the D-dimer. I could spend some time talking about thresholds in D-dimer and FEUs and D-dimer units, but maybe I'll wait and see if we have questions on that. That's always another problem, but not the focus of my talk. But assuming we're using the standard cutoff, it's safe to double the threshold in patients that are pregnant that have a low pretest probability. And that is really given to us by the years protocol. But adoption of D-dimer is slow because the doctors perceive it as a waste of time. And we know that only fewer than a quarter of active practicing emergency physicians really even know about age adjustment of the D-dimer, and even fewer than that use it. We've only seen modest effects on computerized decision support, and doctors will often game the system to order a CT. And they don't really do a good job of determining, when we do research, about doctors' decision-making and their underlying desire to find pneumonia on CT scans, since pneumonia is more common than PE in most samples. Maybe not MEDIC, but in most samples. This sort of has led to my tongue-in-cheek way of thinking about D-dimer, and this is a joke. This is a joke. I used to tweet a lot, but then just kind of decided that it was kind of a waste of time. But anyway, I tweeted this silly thing talking about the way doctors really think when it comes to D-dimer, and I think it got retweeted about 5,000 times because people thought it was funny. But ultimately, it just ends up in ordering a CT scan no matter what, and then going home and drinking. So it can be frustrating for many physicians. Oh yeah, this is the slide about the confusion in the threshold, and just want to point out the 35 D-dimers have been cleared by FDA, and the FDA just asks about whether or not they do what they say they're going to do. They don't compare different assays, and as a result, I mean, in terms of their threshold, they're not required to do any type of standardization. And this goes back to the fact that the D-dimer is a post-translational modification of fibrinogen that, of course, has been linked by factor 13, then cleaved by plasmin. And it's actually impossible to make a D-dimer recombinant molecule as a standard to be able to set thresholds. And therefore, D-dimer assays have different antibodies with different epitope affinities, and we have all of these different thresholds. And then we got FEUs versus DDUs. FEUs is the typical 500 number, whereas DDUs are usually half that. That's the D-dimer unit. If you ever get mixed up about this, or you're trying to teach learners about FEU versus DDU, the way I try to tell people is the word fibrinogen is bigger than the word dimer, and the fibrinogen equivalent units are bigger than the D-dimer equivalent units. So there, I've taught you something that's incredibly useful. All right, interim summary, the PERC rule is safe and effective and is really now a new standard of care, pretty much receiving 1A type guidelines. And increased D-dimer use can decrease low-value CT scanning, an imperative to this collaborative. And physicians dislike the D-dimer because they perceive it as low specificity, but we can help address that with age and pretest probability adjustments to the net exclusion rate, and that's a new standard of care, even in pregnancy. And the problem of solving different assays thresholds, that continues to be a problem and is one that's not going to be readily solved. and is one that I've myself tried to engage the FDA to help, and the American Association of Clinical Chemists, and I've done presentations there, but really this is up to industry, and I don't think that they're going to fix their thresholds because it would cost them money. Yeah, let's spend a second about pregnancy here, and this is a typical pregnant patient in the second trimester. It is said that the risk of PE increases with each trimester of pregnancy. There's a lot of things that are said about PE in pregnancy that really are not backed up by evidence. And this is just a reminder that we are really afraid of PE in the emergency department. This is a systematic review, meta-analysis that we did of the literature, looking at the prevalence of PE among pregnant patients tested for PE in the emergency department. And what we found was, in combining all of these studies, and these included studies in Europe, that the prevalence of PE in pregnant patients was 3%, which was actually lower than in the overall population. And this doesn't necessarily say anything about the risk of PE, but it says that our tolerance of that risk is extremely low. We order testing at an extremely low threshold for pregnant women, and a lot of them end up with a CT scan of the chest and that concomitant risk of breast cancer. Here's something you might want to try just for fun, again, for your learners, is just try MD Calc and look up the years criteria, for example, and put in pregnant patient versus not pregnant patient, see if it changes the outcome. And it doesn't, because it shouldn't. Pregnancy can be excluded using the years criteria, which was, of course, invented by Menno Huisman. It's just a modification of the Wells criteria. It's asking, if you don't think the patient has DVT, no hemoptysis, and you think PE is unlikely, then it's safe to call them low risk, even if they're pregnant, and use D-dimer. There used to be 0 management studies, but now we had 2 that allow us to go ahead and use D-dimer. And then here is the years criteria that I was talking about before, where if you suspect pulmonary embolism and they don't have any of those criteria that I just mentioned, you can use the D-dimer at the double threshold. And that allows a reduction in the use of radiation imaging. If you need to move forward and do radiation-based imaging of the pulmonary vasculature, I'll just give you the latest systematic review. There's several that are out comparing VQ scan versus CT scanning. And the bottom line is that they are pretty much equal. The technique can matter. I think a lot of people don't realize that the indeterminate rate for CTPA in pregnancy is higher than it is in non-pregnant patients because of shielding and crowding of the lungs and higher respiratory rates. But either one is adequate. I personally prefer doing a chest x-ray if it's negative. If it's clear, moving on to half-dose perfusion lung scanning. And if just for no other reason, we've been using scintillation lung scanning in women that are pregnant for 50 years, and there's just not a lot of negative literature on that. We're not seeing an increase in miscarriages or any teratogenicity that's known, or cancer. The CTPA is less well known, and I'll remind you that the contrast crosses the placenta, it goes into the amniotic fluid, the baby swallows it, and there are thyroid effects that we really don't know that much about. So the bottom line with pregnancy is you can exclude PE with low pretest prob and diameter twice the threshold. It's a new standard of care. And there's no evidence to say CT or VQ is superior. Use either one, and I'll just say VQ's been around longer. I use half-dose perfusion only when the chest x-ray is normal. It's your choice. Now I want to turn more to treatment of pulmonary embolism and some new standards of care that are out, and to talk about how this is another quality measure and probably one that will become more and more important. Now, I put a little reference in here. This is a study by Mark Kovacs, and you see Phil Wells is on there, published in 2000, talking about outpatient treatment of pulmonary embolism. I remember in the late 90s, Phil Wells was presented a poster at ISTH, International Society of Thrombosis Hemostasis, and he was just talking about, yeah, these are the patients we treated as an outpatient for PE, and this was after the Columbus study had sort of taught us that it was okay to send DVT home. I remember saying to Phil, hey, are you going to publish this? And he sort of looks at me, and Phil is very tall. He's about a foot taller than I am, so he's looking down at me. And he says, he sort of shrugs his shoulder and goes, who cares? This is just what you should do. Well, it's probably that simple up in Ottawa where they have a pretty established system of doing things, but it still has not been adopted in the United States. And we do have the American College of Chest Physicians and the European Society of Cardiology recommending outpatient treatments in PE patients with low risk of hemodynamic decompensation. And it's moving toward a best practice, but man, doctors don't do it. There is a need to risk stratify, and there's a bunch of different ways you could do it, but the two that are most studied and that there is more literature coming out, including literature that is in review with a large randomized design comparing Espezi to Hestia. I'll tell you, they're equivalent. You can use either one. Espezi is more of a structured criteria, and this is a checklist, and it requires 6 items. There's a couple of criticisms to this, but the biggest one is that it doesn't include your gestalt, which you need. You have got to have physician judgment to decide whether to send someone who satisfies this criteria home. For example, if they're psychotic or can't understand or adhere or take their medicine, they have no place to go. There's also nothing in here about bleed risk, which is something else we have to consider. So whenever using Espezi, there is always clinical judgment plus these 6 criteria. Some people would argue that you wouldn't want to send a patient home with a SAT of 90% because their bounce back rate is very high. But Espezi is well validated and easy to use. And here's the Hestia criteria. I've modified it, and I gave a reference here to make the need for oxygen and need for IV narcotics greater than 24 hours a little more explicit, because it's hard for me to guess who is going to need doses of narcotics for more than 24 hours or need oxygen for more than 24 hours. The bolded bullet points, that would be the way the original Hestia was worded. And what I have presented here is my version of making it more explicit and simpler to use in the emergency department. But you know what the biggest component of Hestia that matters in an ER? And it's this, third from the bottom bullet, other medical or social reasons to admit. And that flunks or fails out about 30% of patients who have Hestia applied to them for reasons that all of you know working in the emergency department. They've been compared head to head by Jimenez in a paper published in Academic Emergency Medicine. And basically he's found that they are equally good at predicting 30-day mortality, but a little higher kappa for Espezi. Well, of course there's a higher kappa because it doesn't have the subjective component, but if you add the subjective component, these two are fairly equal. And here's the RCT being done by Pierre-Marie Waugh, which I happen to know for sure is submitted for review. And this randomized trial head-to-head compared Espezi and Hestia, and I won't give a spoiler alert because that paper has not yet been unembargoed, but suffice to say things aren't going to change. The question that comes up about outpatient treatment of PE of patients who are Espezi negative or Hestia negative is, what if you have a positive troponin? Well, the answer is you very seldom have a slam out positive troponin. Usually it's borderline. If it's really positive, you need to be thinking about possible other myocardial injury like acute coronary syndrome, because a positive troponin definitely increases the mortality risk, as shown by this meta-analysis by Stavros Konstantinidis in the European Heart Journal last year. You clearly have an increase. Here's what I suggest. If you are doing an outpatient program and the patient is Espezi or Hestia negative, and you got a positive trope, at least put them in obs for 23 hours and trim their troponins. I think it's unwise to send them home if they have a slam out positive troponin. Because we're talking about a practical group of folks and drug access and adherence is important, I just want to point out that this can be a problem, especially for Medicare patients that are in the donut hole. But in the emergency department setting, whether you prescribe rivaroxaban or apixaban, which are really the only two drugs that you can use in monotherapy without injections, they're always free. And all you have to do is Google patient 30-day card or free access. You can Google anything for apixaban or rivaroxaban, and you can get this card. And literally, the patient can put it on their phone and take the prescription to the pharmacist and get 30 days worth of drug, full dose anticoagulation for free. And it doesn't matter their insurance status, and it doesn't matter whether or not they have Medicare or Medicaid. But for me as an ER doc, sometimes that's a stopgap measure while we're trying to figure out things like getting them qualified for a foundation, or maybe just getting them followed up with primary care or a clinic and let them deal with it, sort of kicking the can down the road when you're getting killed in the ED. But you can always get free card for the patient to get their medicine. So how does this really work? You know, I want to present you some new data. This is the methods paper, the protocol paper has been accepted at BMJ Open, but these are unpublished data that come from my group. I call this group the MATH VTE group, monotherapy anticoagulation to expedite home treatment of VTE. And this was an implementation trial that we did at 33 sites across the United States, and we just wrapped it up right pre-COVID. We had our last patient in and did data lock. And the way we did this was bundled DVT and PE together and treated them with DOACs, either Riva or apixaban, and risk stratified everyone the same, with the idea that DVT could be PE. At least a third of patients with DVT have silent PE, and unless you image, you don't know which third. And DVT can convert to PE in any instant. Also, it's not like we're already sending DVT home. I mean, doctors talk about it, but fewer than 25% of eligible patients with DVT are treated at home. So there's still a lot of room to go with DVT and way more room to go with PE. So we just bundle it and say VTE, the whole thing. Well, we enrolled 1,421 patients, including 518 at 33 sites. The primary outcome was the frequency of new or recurrent VTE within 30 days. And that happened in only 14 out of 1,421, a little less than 1%, with 95% confidence intervals below 2%. And bleeding, and this was this definition of bleeding, was any patient who returned to the emergency department and was admitted with an instance of bleeding. This is not an ISTH severe bleed. In fact, only 1 of 12 patients received packed red blood cells. None received surgery. None died. None had an intracranial hemorrhage. Most of these people had some type of gastrointestinal evidence of hemorrhage and were anticoagulated and got admitted because no one wanted to send them home. Top limit of that confidence interval is 1.5%. So this is evidence of efficacy and safety. There was one signal that's very concerning in this implementation trial, and that was a very high non-adherence rate at 30 days. 8% of patients either self-discontinued or never started or never filled their prescription, and those patients were at the highest risk of these 14 cases for having VTE recurrence within 30 days. And then we did some interviews with the patients to ask them why they didn't adhere. And the most common reason was economic. And that could have been solved had the doctors, had the staff done a good job of letting the patient know about the 30-day free card. And apparently the patients didn't know it. So about half of the non-adherence was the patients said they had financial problems getting the medicine. So in summary, outpatient treatment for DVT and PE is now a standard of care in an emergency setting. It's got clinical practice guideline endorsement. I'm providing you with new evidence, and there's more coming down the pipe. You can use either Hestia or Espezi plus clinical judgment. And you know what I like to say to kind of ease things off? This is from Jeffrey Weitz. He's another Canadian, been in the PE business for a long time. And what he likes to say is if they can walk in with their PE, they can walk out with their PE. And there is some truth to that. This is something that I would like to see the collaborative interested in looking at. Now I'm going to wrap up here in the last few minutes by talking a little bit about some what I would call research and perhaps a little bit more provocative and controversial components of this talk. And this gets into the research zone. And when it comes to research, mentoring is very important to me. And this is one of my mentees, Lauren Stewart. And, you know, a strong woman in medicine and a strong woman in research. We need more of that. And so I'll put her picture here. And her area of growing expertise is the role of metabolic syndrome in patients with venous thromboembolism in the emergency department. And what I'm going to come out is say something that I think you don't do right now, and I bet you'll do a little double take, but this is what I think, is if the patient is not already taking a statin, and you diagnose PE or DVT, you should order a lipid panel. Now stop there for a minute, because you're probably thinking, well, that's not my job. That's a primary care physician's job. I don't order lipid panels in the emergency department, but I think you should, because it's a patient-centered issue. And here's why, that is that about half of patients over 40 with VTE are going to have an LDL that's greater than 190, which is a 1A indication for statins anyway, just for cardiovascular risk reduction. You don't have to have them fasting. Doesn't matter if they just ate. The LDL isn't sensitive to that. It's the triglyceride part that they have to fast for. And I don't care about that. All I care about is this LDL. And if it's above 190 and they have PE or DVT, and you want to benefit the patient, get them on statins if at all possible. And look at this odds ratio for the risk of VTE recurrence. This is a paper Lawrence published. This is using the massive IMPC database with 125,000 patients in this study. And out of all of the risks for recurrent VTE, hyperlipidemia was the strongest, with the other metabolic syndrome components being stronger than even a history of cancer down here. Metabolic syndrome really increases risk, especially hyperlipidemia. I think it's reasonable to say order a lipid panel on all patients with PE and DVT. Is it standard of care yet? No. I'd like to see it get there. And this is just some visual proof of the metabolic syndrome effect on VTE recurrence in, this is that large number of 75,000 patients with VTE. The previous odds ratio was 125 because it included DVT and PE. And this, look at the red lines compared to the black lines, and these are the presence of each of these components of metabolic syndrome compared to those that did not have the component. And why use statins? Well, there's now a meta-analysis out of 36 studies looking at VTE recurrence. Most of these are secondary analyses of other RCTs that had another primary endpoint. But it's pretty clear that the relative risk is lower if a patient's on a statin. And it's actually, the effect seems to be strongest in DVT and for the rosuvastatin version of the statins, which is the most commonly prescribed out there. And here's some propensity matching that Lauren did that's just now out in the American Journal of Medicine, talking about the strength of statin use as a preventer for recurrence risk. And if you can get them on a statin, it is a safety measure. And one of the worst things for quality of life and cost and just everything for a patient with VTE is a recurrence. Recurrence of VTE severely degrades perception of wellness and quality of life. And a statin can help prevent that degradation in quality of life. And just a reminder, this is a 1A recommendation, and I'm just showing something from the American College of Cardiology, that if patients have an LDL greater than 190, they should be on a statin. And that has nothing to do with VTE, or maybe something to do, but that's all just about cardiovascular risk reduction in general, with tons and tons of randomized trials backing that. Now, I mentioned VTE recurrence because I want to wrap up with a topic that's extremely important to me, probably to you, and you might not even know it, and to patients with venous thromboembolism for sure. And that's this thing that I call thromboneurosis, and I don't call it that in a pejorative way. It needs to be an ICD-9 diagnosis. Thromboneurosis is the consequence of being told you have a blood clot and really not having any good explanation for it, and knowing about the risk of recurrence, and hearing what doctors and nurses and family members and grandma and the TV tells you about your risk after you've had a blood clot. Even if it's a calf vein thrombosis, patients can get this. These are some data from a person named Hojan out of Denmark. And because they can follow all of their patients linked to basically an NPI type number, they can find out their long-term outcomes after diagnosis of venous thromboembolism. And what these plots show here on the y-axis is the risk of being prescribed a antipsychotic or psychotropic drug or sedative hypnotic after diagnosis of venous thromboembolism, the dotted line being cases, those that had VTE, and the straight line being propensity matched controls. Patients with VTE end up getting diagnosed with anxiety and depression and end up on medication much higher than the cases that are equally sick. And this is just a risk plot over on the right of being prescribed a drug compared to not. So it's this replotted another way, the left-hand plot plotted another way. So this is some background data that talk about thromboneurosis. And these are some novel data that are unpublished right now and being done by Jacqueline Hernandez, another one of my mentees in the area, a Latina researcher who is interested in understanding the root cause of thromboneurosis, the psychological mechanisms, and what we can do as emergency physicians to help block this. There's now about 6 papers that have done focus groups of patients with VTE, recognizing focus groups as a biased sample, but 100% have some evidence of post-traumatic stress disorder. And ongoing focus groups, and this work being done by Jacqueline, shows that we make things worse. And here's some large population data, 72,935 patients with PE. And I just want to show you something for inference. And that is the percentage of patients who had one of these diagnoses made after PE was diagnosed. Cancer, that was only 18% this is way over a 5-year follow-up, had cancer diagnosed after PE. This is always a concern if you have an idiopathic PE. Am I going to miss a cancer that's hiding somewhere? And lots of evidence that that's not really the case, although 18% did develop cancer. Many more develop these other diseases. It's not surprising that you'll see a higher rate of GI bleed after diagnosis of PE because people were put on anticoagulants, so GI bleed increased. But look at the most common 2 diagnoses that occur after PE diagnosis: depression and anxiety. Over half of patients with PE get diagnosed with anxiety or depression. And you know what? We make it worse. And I want to show you some transcripts off of in vivo from the work that Jacqueline is doing. And these are the words that the patients heard and remembered. And these patients were interviewed between 6 and 23 months after their diagnosis. So they remembered these words and carry them around and to some extent are haunted by them. But these are words to not use. They remember somebody saying, usually somebody in your situation would be on a respirator and can barely breathe on his own. Another one, I was so dangerous. Patients see themselves as bombs about ready to blow up. I was so dangerous 10 minutes ago that I wasn't allowed to walk to the restroom by myself, but now I'm healthy enough that I can go home. This sentence has several connotations. One is telling patients how dangerous they are, and the other is walking. There's nothing wrong with walking with DVT or PE, and it most likely decreases the chance of propagation of DVT and ultimate PE. Patients can walk if they have blood clots, and I don't care where the clots are. Even if they're free-floating DVT, they can walk. Because for somebody to stand over you and tell you that you've got to have this surgery now, because if not, you're going to die. I know that none of us would imagine saying that to a patient, but that's what the patient heard. And this was a patient that was treated with one of our, level 1 PERT team things, where somebody came in and said, you've got to have this catheter done. And the patient perceived it as surgery rather than catheter directed lysis. And then the last one, but they were all in a hurry and they were bringing machines and to hook me up to this and that. And I didn't have a chance to say, please explain what happens to me. I don't understand. Well, we could say that about pretty much every patient in the emergency department. And that last one is just a reminder that, when I approach patients about informed consent and research studies involving pulmonary embolism, and this is not an exaggeration, at least 60% of them are receiving heparin and don't know they have a blood clot. And we think they know what they have, but they can't read our minds. Communicate, it matters. So those are words that don't help, and I just wanted you to see some of those and think about how the patients have these persistent ruminations that lower their quality of life and increase their risk of a PTSD-like phenomenon. So here's my summary. If patients are low risk with PE or DVT, they can go home on monotherapy. That's a new standard of care. If they're normotensive, and meaning they have low risk and their trope is negative, you can just anticoagulate them. If the trope is positive, better not send them home. At least watch and wait. They don't necessarily need lysis. That's another part of the talk that we don't really have a chance to get to. And every patient that's hypotensive, I didn't cover this, but I just want to remind, if patients are hypotensive, they need some type of reperfusion therapy. They don't need to be going home. So to wrap up, here at about 45 minutes, leaving plenty of time to talk and have some discussion. Use the PERC rule. It's 1A, it's ready for prime time. Order more D-dimers on all patients, including pregnant patients, and use threshold adjustments for age. Use threshold adjustments for pretest probability, meaning those with low pretest prob can have a double D-dimer threshold. Patients that are pregnant and have a low pretest probability can have a double D-dimer threshold. Treat low-risk patients with DVT and PE at home, and consider ordering a lipid panel in all VTE patients that aren't already taking a statin. And tell your patients with PE they're going to be okay. You won't regret saying, we caught you. You are in my care. You are going to be okay. All you have to do is take your medication. And please don't be part of the 8% who never fill their script at 1 month. So that's it for my talk, and I look forward to answering some questions.
Thank you so much, Jeff. I know Megan's been working in the background here, collating some questions. I certainly have some of my own. I think to lead off, probably a lot of people in our collab want to know what you think about our MEDIC consensus-derived algorithm, and I putting you on the spot, and I know you probably haven't really looked at it well. I think it lines up pretty well with what you're laying out in that first slide or two that you were showing, where we walk through a pretest probability of gestalt assessment before branching into PERC versus Wells. And ultimately, I agree with you. I think age-adjusted D-dimer is a important, impactful practice change that we're hoping to achieve across our sites. But any comments about that, just to start?
Sorry, I was just looking at the questions here. The algorithm is great. I don't think that the MEDIC algorithm needs to be improved. It's all about adoption and persistence. And I don't think anybody can make a big difference unless there's measurements. And it looks like you give report cards, you feed back on doctors. I can tell you pretty good evidence that if you just lay it out there and you do a CME course and try to teach people to do stuff and you don't follow up and enforce it and show emails that show how you compare to your colleagues, it's not going to make much of a dent. And I've tried that before, and I've been part of multiple different methods to come in and try to improve quality of CT scanning. And unless there's the compliance component, which I don't know what the right, compliance is the right word, the feedback component, and not necessarily public shaming, but showing people how they compare, because doctors and providers are generally competitive and want to do a good job, it won't help. I'm interested in whether you agree with that or not. I don't think it's so much about the perfection of the algorithm as it is the perfection of the feedback.
No, I personally, speaking for myself, being in, this business, learning a lot along the way and shepherding, our collaborative along with all our partners, I agree. I mean, I think it's about connecting with clinicians in the ways that intrinsically motivate practice change, that this is the right reasons for doing care in the ways it is, that we are following evidence that there is room for improvement. You got to connect sort of to the clinical motivations rather than, some external, financial incentives. While we have those in place, that's not really about, I think, what motivates people at the end of the day.
Seth Krupp asked, why not just use low-risk wells? And I would say because there's no management studies. I don't know that it gets you to 1.3% chance of PE, and I don't know what the confidence intervals are around that. And I can tell you that in my data sets, it performs almost as good as PERC, but we end up with confidence intervals that are above 2%. I think it's fine. It's just not validated.
Megan, are there other questions coming in? I personally can't see the ones that might be in the Q&A section.
Yeah.
Yes. Yep. We have a question from Dr. Brennan from DNC Sinai Grace. Her question is, you mentioned age-adjusted D-dimers several times. In our institution, we argue about how to do this. Does it require a special assay?
No, it depends on which assay you're using, and that threshold can get confusing. For the standard assay, it's 10 times age. If you have the hemocil assay, that's the most common one that uses the D-dimer units, and it has a weird cutoff that can be 238 or 243. I mean, just assume its cutoff is 250, and you use 5 times age for the hemocil. That's the one that uses the D-dimer units. So I hope that answers that question. There was a corollary question to that about using age-adjusted D-dimer. Has it been demonstrated that it has been associated with a decrease in CT use with implementation? And I'm not going to be able to pull the references out right off the top of my head, but there are several that are before and after QA kind of studies that have demonstrated a decrease in CT scan usage and an increase in yield rate. So some evidence of outcome with age adjustment has been shown.
A question from Dr. Benjamin at St. Joseph Mercy Hospital in Ann Arbor. Can you comment on using VQ or even just a Q scan if perfusion is normal and radiation exposure? I consider this with adolescent/young adult women who are PERC positive with positive dimers to avoid chest wall radiation. Radiology suggests radiation is so low in CT these days, this may no longer be a valid alternative.
I mentioned it in pregnant patients, and a Q scan with a normal chest X-ray is going to have fairly high specificity, above 75%. It's not going to have the specificity of a CT scan. And, with dose modulation, a CT scan, I know that they are decreasing their, the millisievert radiation dose. I have to defer to them and their phantom studies and what exact protocol they're doing. I do want to say one thing is when you're doing dose modulation of CT scan, without a doubt, you lose you lose quality. It's pretty funny. I'm just going to make a tongue-in-cheek comment here. About 20 years ago, when we first started using single head detector scans, you could basically see down to about the segmental pulmonary arteries, and you could not see subsegmentals. And then with the multi-detector row head scans, we could see the subsegmental PEs, subsegmental arteries. And with more radiation than a single head. But that led to the whole subsegmental debacle of whether you see a single subsegmental defect with no DVT, does that patient need to be treated? Raised lots of concern. And then now the engineers and radiologists are coming with dose modulation CT scan using the multi-detector scan. And basically they've made the imaging look exactly the same as it did 20 years ago. You can't see the subsegmental arteries. There's lower radiation. So it's sort of, we sort of took this technology and kind of made it worse so that it looks like what it did 20 years ago and gives about the same information. So I don't know what to say about that, is that I do think that, that the lower dose modulation is the way to go, because it solves two problems, and that is breast radiation and also the subsegmental PE problem.
Any other questions? Yeah, Megan, another question?
Yeah, one more here from Dr. Plemons from Henry Ford Wyandotte. She notes that she developed their outpatient DVT protocol, and it would be very easy to move into PE outpatient treatment, but she's curious about getting their medical staff to support this. Do you have any ideas on how to get their support?
Yeah, they need clinical practice guideline endorsement. So the first thing is to just point to what ACCP said and what ESC said. And you know what else they want? They want literature. And, you know, I've shown you an implementation trial that we've done that is not published. It's, you know, this is the, you invite a researcher. I want to tell you about my research. It's not out there yet, but I think that will help. There are other large studies that are out. The home PE trial that Pierre Marie is doing that I referenced is in review. And then there is the HOT PE study by Stavros Konstantinidis that was published in the European Respiratory Journal. And so more and more evidence is coming down. I think they want to see this safety, and they want to know that, like, this is what I'm supposed to be doing. I guess ultimately when someone comes along and says, we're not paying for this admission, then that will really clinch it, but we're not there yet. So I think that you can be ahead of the curve by telling your staff and your colleagues that this is a best practice, there's new evidence happening, and it has clinical practice guideline endorsement, and will continue to have more and more endorsement.
I'd add, I mean, I think it's something that we may consider adopting as one of our quality initiatives in the future. I mean, we certainly, in the next couple of years, will want to bring online some additional areas of care, and certainly one of our areas is around the hospitalization decision. Certainly PE, I think, is one of those conditions that could be a target.
Yeah, and may I say, I would be interested to see how many DVTs you're sending home. And again, there's a big gap between what people think they're doing and what they're actually doing with DVT. And I showed 3 citations which all show that fewer than 25% of eligible DVT patients are actually sent home. Now, it doesn't get to why. They could have social reasons. I don't know, but the percentage that are going home with DVT are not as high as a lot of people think.
Yeah, it's a great point, and certainly broadening it to VTE makes a lot of sense, particularly because like PE numbers tend to be smaller, just volume-wise than DVT. So there's more opportunity for improvement there.
It's 2 to 1. 2 to 1.
I do have another question. I don't know, Megan, if we've got more from the audience. Okay, you gave me the thumbs up. I'm curious, Jeff, as you sort of see into the future, you know, we're in the implementation side, the quality improvement side. I mean, are we done with like deriving clinical decision rules for PE? I mean, we seem to have new ones every year almost. You know, what may be next? I mean, machine learning, artificial intelligence is a way to sort of make the, you know, Gestalt CT decision. What do you think?
Yeah, I think we really solved the problem of pretest prob and the dimer, and I think the CT is a good test overall. This is a much different problem than it was 20 years ago. And, you know, part of the whole reason that COVID looks like it's so thrombogenic is we screen way more than we did with H1N1 influenza, which was also thrombogenic. You know, we kind of have this problem under control, and I think, you know, sort of fine-tuning the threshold is really important. Now let me try to address your question as a person whose life is immersed in this in lots of ways. including that as an expert witness in medical malpractice cases. And there are still hundreds of people dying every year from pulmonary embolism that should be alive today. It is not as many as it used to be, but the reason they die is the doctor or advanced care practitioner doesn't think about PE appropriately, meaning out of the gestalt. Who is it that rises to the threshold of starting the PERC rule or starting Wells criteria or starting even gestalt? Once you start thinking about PE, the patient is safe. I always teach my residents this. You are not going to kill somebody once you start thinking about PE. It's when you don't think about it. So that, to me, Keith, is where the real research is. It could be machine learning. I've done a lot with machine learning over the years. I think it's advancing, and there could be flags that you need to be reminded of. Usually in med mal cases, there is a signal there that is a hard signal. Sometimes it's not, but just knowing when to begin to start thinking that's where the life and death decision is. How do you teach Gestalt, or how do you supervise it, perhaps with something running out of an electronic medical record? I don't have the answer right now. I think it's lectures like this, it's training, it's the skill and thought processes of the people on this meeting now, teaching others to think about PE. But don't be scared. Don't order a test just because you thought about it. Mm-hmm. Use your mind.
That's great. Well, let me give one more opportunity for any other questions. We do have another question.
I see a couple.
Okay.
Kline, this is Michelle Nypaver. I'm the co-director of Medic. You let us know that you were starting to think about working with PCARN, and I don't know, without revealing too much, if you can give us a little bit of some insight. I live in the land of young adult women on oral contraceptives who frequently are complaining of chest pain, and the pediatrician in me says don't do any CT scans. On the other hand, which ones deserve these? It's a very important question for us.
Right. And, this is probably why this, I put a lot of applications into the NIH, and I get a lot of not funded applications, and this one got funded, I think, because the panels recognized the significance of this problem. We have nothing to go on in young adults, meaning those, that are teenage. There's not a single prospective study done on the diagnosis of VTE at all. So this study is called BEEPR, Bedside Exclusion of Pulmonary Embolism Without the Use of Ionizing Radiation in Children. And again, we're using a modified version of the PERC rule. And it's not a management study. It is enrolling all patients that have D-dimer or CT scan or a test that was canceled. And we are looking at their 45-day outcome. So this will be done through the 18 PCARN sites plus Indiana Raleigh Hospital. So not ready for prime time. Everything is retrospective at this point. Even the D-dimer is not well known in children, with highly disparate findings ranging with sensitivities between 79 and 100%. I wish I had a better answer, but it's the need for the study.
Can I ask, what's the age that you're studying this in, this rule in? I'm just curious.
Yeah, under 18.
And is there like a lower bound to that age, I assume, like, 12 and above or something, or?
Yeah, above 3, so 4 to.
Okay, yeah, that low, okay, yeah.
Yeah, we do think infants are different in that they have different reasons. The infants get clots, but they're usually in the NICU, so it's not something that we think we're ready to put in. There's a question I'd like to. I hope that answers that question about children and young adults. And thanks for letting me talk about it. It's 11:01, but there's a question I wanted to address. It's from Angela Madrano, and it's other than words of encouragement, are the suggestions to prevent providers from causing the discussed mental health impacts. And no, at this point, peer support, referring patients for counseling, we don't know any signal of efficacy for that because it's not been tested. I'm just going to hold out that it's self-evident that there's nothing wrong with words of reassurance. Reassurance is some of the most powerful medicine that is understudied. It is stronger than placebo effect, and patients with clots need to know that they're going to be okay if they take their medicine. Their probability of survival, even with severe PE, is 95%. There's nothing wrong. No one is going to come back and tell you you're bad. If you tell patients that have clots, you're going to be okay now. I got this. I caught it. This could have been serious if we didn't catch it, but it is easily treated with this medication that will prevent future clots. Oh, and by the way, please don't use the word blood thinner. I hate that word. That word makes patients nervous. It's not thinning the blood. It is preventing clots. Please call it clot preventing medicine or medicine that stops clots, or even use the word anticoagulant. But blood thinner is another thing that patients think means that they don't have enough red blood cells and that their blood is going to come out of their ears, or if they cut themselves, they're going to bleed to death.
We have several more questions. I know we have just a few more minutes here, Dr.
Yeah, I
Kline.
mean, we have certainly another 10 minutes, so let's keep going. Yeah.
So this question comes from Dr. Dennis at Beaumont Troy. Considering medic performance goals, including value-focused evaluation for PE, are based on data established using participating site data prior to the advent of COVID, how do you see COVID affecting the likely yield of CTA for PE studies? Do you feel it is likely there will be more studies ordered due to concern COVID is a thrombogenic disease? And might there be a lower yield due to greater numbers of studies, or might the yield increase due to greater prevalence?
Thanks for the question, Dennis. And I anticipated this. In fact, I have a talk called Clots and COVID. And, we spend a lot of time addressing this. And I'm going to give a little bit of a contrarian statement. And that statement is that I don't think that SARS-CoV-2 is much different than any other severe viral infection in terms of its thrombogenicity. It got a lot of press early on. It is possible this virus has mutated and it is less thrombogenic now than it was when it was moving across China and into the Netherlands. There's two papers coming out. One is, again, by Jonathan Freund. Jonathan did that proper study for PERC that I'm talking about, where he has shown in propensity matched samples that the prevalence of PE on CTPA scan was 15% in multiple institutions around Paris prior to COVID and 15% afterward. There is another large study that is being published in the European Heart Journal, again from a French group, not Jonathan, that is a large multi-center study that shows the prevalence of PE and CTPA being done in France is 8%. So those numbers are lower than what we saw pre-scan. So I think your sense that the threshold has lowered, that more people ordered CT scans than would have, is true. I can tell you that in our registry, I didn't present these data, but I have a thing called the Recover Registry, which is 43 investigators representing 150 hospitals across the United States. We now have 17,000 entries. And what we're looking at are patients that present to the emergency department with symptoms and are tested, have an RT-PCR swab done for COVID. So we have 1/3 that are positive and 2/3 that are negative, allowing some case control comparison. The prevalence of VTE in the patients who are COVID negative, 1.7%. The prevalence of VTE, and this is with 30-day outcomes, of patients that are SARS-CoV-2 positive is 2.7%, 2.7 versus 1.7, so a relative risk or risk ratio a little over 1.5. Not super powerful, not super impressive. But yes, it is no doubt that it has modulated the threshold of D-dimer and CT scan ordering. And I know about all the concerns of the CT scan magically being contaminated by patients with COVID, but there's still a lot of CTs being done.
Yeah, and I'll add, I mean, we have yet to really dig into our own registry data. We have some data catch up to do because many of our abstractors were tasked to other areas and hospitals during the pandemic. But it'll be interesting to see like what our own registry data looks like. I think it's mixed. I think we see some increases in diagnostic yield, some drops in diagnostic yield. I think it's complicated for exactly what you said, Jeff, because some people may have been less likely to use the scanner just because of the problems of decontamination afterwards too. And we're just treating empirically, and those would not necessarily be things that we would pick up in the ED per se. Any other questions,
Yep.
Megan? Yeah, okay.
Another question here from Chris Port. What is your opinion on mechanical thrombectomy? What criteria should be utilized on when to consider it for DVT?
Okay, the question is focused on DVT, and allow me to offer that I believe you're going to see a lot more suction catheter use for patients with pulmonary embolism. There's one in particular by Inari called the FlowTriever. There are others, and these devices work as well and faster and safer than catheter-directed lysis. I believe you will see suction catheters if you're IR folks, and this is almost always an IR, not an interventional cardiology procedure, become skilled and facile with using it. It's a great device, and it definitely lowers PAPs, and it lowers them fast and better and safer than catheter-directed lysis. Now that's PE. DVT, mechanical thrombectomy, usually this is pharmacomechanical, and the one trial we have is the ATTRACT trial, which was the paper of the year in the New England Journal in 2018, and basically found no difference in the development of thrombophlebitis for those that were randomized to receive catheter-directed treatment for DVT versus those that didn't. In a subset analysis, those that had high and tight clots, and I call high and tight clots, those are up in the common femoral artery above the takeoff of the saphenous or at the takeoff of the saphenous, those patients did benefit. So there's still this question of, if you like it, you can make the data say it is good for the really high up clots. What would I want for my family member? If I saw a high and tight clot, one above the saphenous vein, and the patient and my family member had a swollen, painful leg, I would want it for that family member, because those are the ones, the subset of the ATTRACT trial, that were likely to benefit for DVT.
Thank you. Another question here from Dr. Dennis at Beaumont Troy. Knowing that prior to the availability of high-resolution helical CT for PE, autopsy data indicated it was not uncommon for individuals to have experienced pulmonary emboli, which were undetected and likely of no clinical significance. Do you feel all PE, including subsegmental, represents disease concerning enough to warrant treatment and requires study for detection? Or is it acceptable to acknowledge there may be some small pulmonary emboli we do not need to detect, as they would not warrant treatment and therefore do not need to investigate to find?
All right. Well, thank you for that question. Again, it's a good one. And I don't know if folks can see my face, but I'm taking my glasses on and off because I'm old and I need them to see, but they have a glare, so I'm trying to take them off because it's kind of weird to look at somebody with glare in the glasses. So I'm going to give you my summary that I know over doing this for 20 years, and that is that the job of the lungs is to catch clots, and to the best that we can make inferences doing scans on asymptomatic patients that had scans done for staging of different diseases, including cancer, which is a risk for clots, that you can find about 1 to 1.5% of people walking around on the street that are over age 40 with a filling defect consistent with acute PE and no symptoms whatsoever. There's anecdotal things that say you catch a lot of clots in your lungs and never know it. Surely someone in this 106 participants has had the experience where you have done a bedside ultrasound of the common femoral vein and seen a big clot there, and there's a clear-cut compression defect. You can see that white clot in there, and you record it, and then you bring a learner over and say, hey, I want to show you this DVT, and you go to the same vein and it's gone. The clot is gone. Now, where did it go? You look up at the patient and you expect the pulse ox to be 0 and the patient to be in distress. They don't feel a thing. Nothing. And I know where that clot is, but it gave them no symptoms. Yes, there are many asymptomatic clots, and the subsegmental PE problem, I think The radiologists helped us solve the problem by doing the dose modulation and making it so they don't really see the subsegmentals as well as they used to. And I also think that they've done a good job of kind of quietly stopping the call of all those single isolated subsegmental defects. I see that problem as waning rather than waxing, the subsegmental problem. I think kind of everybody sort of implicitly got on board that these people don't need to be treated. We published a systematic review looking at what was available, looking at the treatment versus not treatment of subsegmental, and in general, things were worse with treatment.
Thank you. The final question that we have on here is from, sorry, go ahead, Keith.
Yeah, I was going to say, let's do one more question.
Yep.
So,
From
yeah.
Dr. Krupp at Henry Ford, Detroit. When are insurance companies going to make it simple for us to just prescribe DOACs, D-O-A-C-S? This is a limiting factor that causes observation/admission to be fallback, often due to headache of dealing with logistics of pre-authorization, free prescriptions, et cetera.
Yeah, I think when the Medic Collaborative shows them that it'll save them money.
Yeah. All right, I'm getting a thumbs up, and we are definitely right at time, which is awesome. So thank you so much, Jeff, for your wisdom. You can tell by the questions, so many people were taken by the subject, and is such a, at the heart of what we're doing here. So thank you so much for your time. Really appreciate connecting with you, and we'll hopefully run into each other in the future. Thanks so much. And for the rest of you in the collaborative, we're going to take a 5-minute break here. Well, I guess 7-minute break. So we'll come back at 11:20. We'll see you shortly. Thanks. Welcome back, everybody. Hope you had a nice coffee, maybe. Relax a little bit. Let's shift into the second half of the meeting. We have 3 things to cover. I'm going to go first. And let me see if I can set this up. We're going to talk about disparities. So I think we all recognize the moment that we're in. These are a few statements from professional societies within emergency medicine on the subject of racism and healthcare disparities. I think for us within especially emergency medicine, there's been some work describing disparities that exist in care delivery, in some of our outcomes. Here are a few examples from the literature. I don't think it's been as well described within emergency care as it has been more broadly in healthcare. But these are real, and I think for the Corning Center, we began to sort of wrestle with this reality and began to ask ourselves, are there areas of care within our quality work where there are disparities? And so I want to present some data here, not with the intent of coming to conclusions, but more with the intent of introducing the idea and proposing a next step. So I'm going to use adult head injury as a case study. But I'll present the other quality initiatives as well. We started collecting race and ethnicity data 2 years ago in our registry. This is the adult head injury, minor head injury cohort. So first, just to answer the question of to what extent do we have missing data for race and ethnicity, this is what this table is showing. So we actually had complete data for half our sites that are in this analysis, and really just small amounts of missing data in the other 8. Again, this is with respect to the head injury cohort. So we're not worried about having missing data. I will say that the quality of the race and ethnicity data is totally dependent on what exists within the administrative health records of the sites that we get our data feeds from. But I think that's pretty standard when you do these kind of analyses using administrative data or claims data. So we looked at 1 year of data. Most recent data, basically up until COVID pandemic hit Michigan, so up through February of this year. We did exclude a couple sites. Some of these were children's only hospitals, which is because this is an adult head injury. We also decided to roll the other race category up, and you can see what that encompasses. It's certainly imperfect, but I think it's important to show as well. So what we're showing here is the performance across the collaborative on the appropriateness head injury measure. And you see across black, white, and other that there actually are differences here where up is the higher performing. These are statistically significant for what that's worth and meaningful. Here's a look at these same data by site. So we blinded the sites. We're not calling anybody out here specifically. Again, up is better. I highlight 2 sites here. One in yellow where there are these differences, disparities in performance by race, and one where there aren't. And I think that's telling too, where we see some unevenness across our sites in their performance by race. Again, I'm going to show the other quality initiatives as well, because I'm sure you're wondering about them. But we didn't do as deep a dive here. So here's diagnostic yield. So the PE measure up here is also better. And we also see some differences not reaching statistical significance between the black and white categories, but there is this difference statistically significantly relative to the other category. Here is the pediatric head injury. This is the intermediate risk measure. So in this case, lower is better. And you can see actually it cuts a different way. And there's certainly, I think, a lot of hypotheses that you could field around why it may cut differently with this particular measure. And then here's the respiratory cohort. So these are the children with bronchiolitis, croup, and asthma, and the frequency with which they're getting a chest X-ray for these associated with these conditions. The differences are here, not as large, but still some difference. So we're not in a position to draw deep conclusions here. That's not the intent of presenting these data. I think there's some things that we can say in that there are differences in our performance at the collaborative level by race. There's unevenness around that performance. There are certainly lots of potential sources and root causes for those differences that we can't tell from these data. Certainly questions about differences in severity of illness or the type of clinical presentation may be different by population. I think there could be differences in the way that the ED care process occurs by race. Decisions around triage assignment, for example, trauma activation, those may play a role in our measurement outcomes here. But I think you really have to consider, could there be implicit biases behind these numbers? And we can't tell that, obviously, from these numbers. But this is what we would propose from the Corning Center as the next step. We think, MEDIC has a responsibility here to close disparities in quality. But that's not something that the Corning Center can do on its own. We really need collective engagement. And I think it begins with first understanding our own registry, doing the analysis, doing the interpretation of that analysis so we can better understand, what are the sources of those disparities. And out of that, I think coming to a plan of action around how we might begin to close those differences through reporting, through interventions, through incentivizing practice change. And so what we are proposing as a next step from the Corning Center is launching a disparities work group, similar to the other work groups that we have sponsored to date, and begin to do exactly what we're proposing here, doing deeper dives into the registry, understanding sources, and putting into place an action plan about how to begin to close those gaps. We're also very mindful that we're only presenting differences by race, but there may be differences by gender that we would also want to tackle. We are also not showing the ethnicity data, so the Latino data in this either, just to make things simple. I'm going to stop there. I am certainly interested in entertaining any questions or comments now. But absolutely in follow-up as well. And we'll be in touch with all of you as we work through these next steps, launching a work group. Megan, I don't know if there are any questions that are coming up.
Yep, we do have a couple different questions. So two people have asked essentially the same question, both Dr. Dennis at Beaumont Troy and Emily Narrator through the Henry Ford system are wondering if they are able to see their own site's individual data looking at race and or a site-specific disparities report.
Yeah, absolutely. I think that's a future direction. I mean, I think that's part of the goal, at least as I would see it with a work group, is to work through how to do that measurement in a way that feels fair and, more importantly, with the eye of improving and closing those gaps, and what that set of reports might look like. Building potentially a set of reports on our registry and on our dashboard so that people can draw on those. So absolutely, I mean, we don't have those data immediately available for you to share right now. That's certainly where our head is too. And it looks like that was the one question. Megan just gave me the thumbs up. But again, this is not the final say, and we want to take these next steps together. But I'm going to pause now, hand things over to the last sections of the meeting. Carrie's going to come on and talk to you. You're probably meeting her for the first time for some of you. But welcome, Carrie.
Thank you, Keith. It is nice to meet everybody in a weird way, an anticipated way for sure. And I'm actually really happy to have this opportunity to share some of my observations that I've had in my 8 months on the job. I'm just now getting the opportunity to tell you about a little bit about myself. You can see up there, I've been a nurse a very long time. I've got a lot of NP experience also, at least half of my nursing career. I was in the medical observation unit, part of the ED, so very versed in these initiatives, and also I was in thoracic surgery for 5 years. And then when I was a nurse manager, I also had quality initiatives experience too, so I have a lot of experience to bring to this job, so I'm pretty excited to share that with everybody. So I'm going to actually be going over 2 different overviews of the modules. First one will be chest pain, and then I'll do the pediatric asthma. Those were the new ones that we rolled out last November, so it's kind of been coinciding with when I started. So I have a lot of invested in these, and then hopefully at some other opportunity I'll be able to share observations for the head injury and the PE. But for now, I've been doing what we're calling the SNAP reviews. It's basically the audits that are done as part of the P4P. And they're actually, we call them SNAP reviews because I don't like the word audit, and it stands for Sharing Knowledge and Perspectives. It's all about teaching and working with the abstractors to get the most out of all the abstractions and have the most accurate information, and to really raise the level of how we're abstracting. So just a very brief overview on the chest pain module itself. We do have 9 module questions that are built around the heart plus T, or the heart score. We do only do a sample of 60 chest pain cases per month because of such a broad number of chest pain cases that come in. We had to narrow it down to 60. Those are sampled cases. And of course, this measure only addresses when it's appropriately to discharge a low-risk chest pain patient from the ED. And I'll show you examples of the questions that we're having, and it really follows the heart score. We do look at the history, the risk factors, the troponins, and the EKGs are all manually abstracted. The age is collected electronically and pre-populated. And so based on the above, even though we ask you later in the ED visit or in the module itself if you've calculated a heart score, the module itself also calculates a heart score based on what we're inputting into the module itself. So here is a reminder of kind of what this is based off of. And what I'll be pointing out to everybody in a little while in my observations, there is very specific numbers. When we're looking at history, EKG, age, the risk factors, and troponins, they all have a calculated score. You can go to MD Calc, you can put these calculations in, you can put your risk, and you will get an actual number. That's going to be important in a little bit. So here is a sample of our actual module questions. So on question 1, we are looking at all those risk factors that go into that. Of course, BMI, smoking, first-degree relatives, that's also going to be mentioned in a little bit. These are all important aspects, and we're combing the chart. And we do realize that a lot of times the ED visit does not always automatically bring forward some of this past medical history. So the abstractors are trained to go search in the chart. So anything that's not in the ED, if we have suspicion on it, we're going to go look for it and trying to verify it. For the second question there, we're looking at the characteristics of what brought them in. because we're looking at their suspicion of how high we think their level is of having a heart issue now. Those are all very specific questions, and again, we can find those in the nursing notes, the EMS notes. Your notes, of course, are most important, so we can look everywhere that's applicable for these. For number 3, that is looking at the EKG's interpretation. So we're looking at the EKG itself, but also very importantly in your MDM is your interpretation of that. We collect all the elements because, again, as a reminder, in the module itself, based on how we're answering these questions, it also calculates a heart score in the module. So as I've been doing these SNAP reviews, there's been a number of things that I've noticed in the documentation and in the charting. And one of the main things is that an actual heart score itself is missing. So some facilities are pretty good about putting a heart score in, and some facilities could probably do a little bit better. What I've also seen is some heart scores are given as a low, moderate, or high risk. They're just telling me a range, or it's below 4. That's not good enough for what I need. I need it to be an actual number because it is calculated as a number, so that is my expectation from all of you also. And then the family history. That is one of our risk factors, and it's very frequent that I'll see right in there that'll say, well, father has heart disease. There's no age. So I have no indication if it's an early onset or if it's going to comply with our family history or not. The EKG interpretations, those themselves are either not mentioned or if they are mentioned, it's just, there's no mention of it other than that's like not worrisome or not intended, which tells us a little bit, that you're not worried about ACS, but it's still kind of like what Dr. Kline had mentioned. If you're not talking about it, we can't read your minds. The abstractors have to go with only what's documented. So certain things we can infer. And me as a clinician, I kind of know where you're going, but the abstractors need a little bit more concrete information from you. So we do include, as I mentioned previously, all the nursing and EMS notes for chest pain characteristics. We can look in a lot of places in the charts, but to do more efficient, and quicker, not that we need to be fast in our module abstractions, but the more you have in your whole history and physical when they come in, then the less places we have to go searching for all this other data. And we also look at the intended disposition from the ED visit. So I do notice a lot of times in that MDM, it'll be pretty sparse and the patient is discharged home, but I didn't see your decision making as to what made you feel comfortable to do that. So I'd like to see a little bit more of that. And then if you have any questions about that, we'll just do, if anybody has questions for me, we'll do it at the end of this part of it. So here we're going to transition over to the asthma module. This is an expanded version of the chest X-ray respiratory module. We have a sampled of 50 asthma cases and 35 bronchiolitis cases per month. The safe discharge measure is to identify when it's appropriate to safely discharge an asthma patient from the ED. There is 18 module questions that focus on the patient's symptoms and their history, what brought them in, what did they do at home, any meds given during the ED visit. We have a whole huge section that includes the medications given and ones that are discharged, and whether or not a chest X-ray was performed. So here's just a sampling of some of those questions, and these are the ones that I find can be a little bit more problematic for either the abstractors to find the information or just the way it's set up in the chart sometimes is a little hard for them to discern and get this information. Believe it or not, the first one is, if there's a fever, that's usually pretty evident. What we don't know is that duration of fever. There are so many conflicting stories. We're just looking for anything within about the past 5 days. So any mention of the duration of a fever is much appreciated. We also need, if there's documentation that the patient was toxic, somnolent, lethargic, listless, or ill-appearing. Sometimes there's no mention of how the patient is actually looking. It just kind of goes right into the assessment. And then for what's question 4 on here, it lists those 7 entries or 8 entries of the actual physical exam. And we are talking about when you actually physically examine the patient, and we're looking for all those particular elements. We actually ask that question for the first, second, and third. So we do that up to 3 times, which I'll have an observation on that in a little bit later. So question 5 is we're looking at the worsening clinical status in the ED despite treatment. So we're looking at all of those. So some of you are doing an amazing job, and you'll literally list out, we've gave 3 bronchodilators, we gave a steroid, this still isn't going on, we had to add high flow, we had to give MAG, we did these things, and we've got that, and we're easy to find it. But sometimes it's not so documented as well. So I'm just kind of asking you to be a little bit more mindful is when kids are not responding as well as we want them to, and we have to add in other interventions, we're trying to capture that, and I want you to be able to take credit for it, so document it. And then for the 6th one on there, we also do give you credit for any prior albuterol or bronchodilator that was given prior to arrival, because we know the decision is being made on giving those 3 bronchodilators and the steroids. So if it's already been given at home prior to arrival, we are acknowledging that, so we're not going to ding you for not doing that level of care. And then we're also asking for all the respiratory medications that are given, and we ask for up to 6 different respiratory meds. So the Duonebs, the albuterol, everything, and that is by route and dose, and it's very inclusive. Okay, so for my observations during these SNAP reviews, especially some of these poor kids, I know everybody's busy. The ED is a very busy place, but there is still scarcity of documentation in both the HPI and the MDM. And prior hospitalizations or intubation is not always noted. And so I've been training the abstractors to go back and look in the encounters if there's anything in your hospital system, anything that we can do. So it's just a hunt system. We have to hunt for these things if they're not actually noted, because I want them to verify if it happened or not. And of course, the duration of fever, as I mentioned before, is very difficult to determine. And then we also have, this is a bigger thing too. It's really challenging to determine the number of actual physical assessments actually performed. We're asking the abstractors to record 3 different ones, up to 3. Of course, you don't have to have 3. But it's really hard to determine what happened or how often. What I'm seeing a lot of times is like, a patient was monitored over time. Well, did you go in and physically assess that person? Did you put your stethoscope on them? I can't really tell. And honestly, we are using the attendings attestation also if they give a physical assessment in that attestation. So we're looking at all the determinants, everybody who's touched the ED people who have touched the patient, then we want to know about it. And then the review systems, that one has not been consistent with the HPI. I've been finding relatively decent HPIs, and then the review system is everything negative. So then I get the abstractors saying, well, they said this occurred in the HPI, but now when they reviewed all the system, they're saying none of this is going on. So it's just conflict of documentation. So for my overall last pieces of this, and this is what everybody knows, right? If it's not documented, it didn't happen. So I know all of you are doing amazing work, and I want that to be captured. So the more that you can put in a little bit here of a note or 2 or a click system or whatever we can do, I'd love to be able to capture that better. We do review all provider notes as well as the nursing notes, EMS notes, and we can, go back, phone call notes, anything that's going to be applicable to those particular module questions we're going to look at. When there is conflicting information, it does take us extra time to abstract these. The chest pain module itself has up to 45 data elements that they have to answer to, and the pediatric respiratory has up to 113 data elements. So they have to either nay or yay on every single one of those data elements. So they have to mark it off or try and find it and make sure if it's there or not. The actual average time to complete a chest pain module is about almost 9 minutes, and the average time to complete the pediatric respiratory one is a little over 15 minutes. So part of my focus has been trying to help the abstractors efficiently move through the charts and how to find all that data. So we're working on that on our end, but as much information as you can put in that initial history and physical, that would be fabulous. And we do have the abstractors expected to abstract at least 28 cases per day, but if they're doing a lot of hunting and pecking, sometimes it can take them 40 minutes just for one particular case. So, because my expectation is the highest level of veracity from all this information, and I'm expecting very high levels from them to find all this information. So it's important that we all work together on getting that. So any questions? Excellent. Okay. So I think I'm going to be able to turn it over back to our final remarks to Michelle and Keith.
Thanks, everybody. I know this has been a virtual experiment for all of us here, and I hope we were able to convey some of the key points that we wanted, moving in the direction we have, the effect of COVID, the importance of the documentation in terms of our data and the integrity of the data. Thanks, Carrie. I know that is an incredible amount of work. So we wanted to say thank you for everybody for putting up with us as we, took our first foray into this virtual assessment and presentation of medics' work. But don't forget, in closing, there is a survey that will be sent out to you within the next 24 hours. And please take a look at that, and please give us some good feedback about what we can do better. We certainly would want that information, as, in order to create new and meetings that will be helpful in the future. Don't forget also to take your CME, and the QR code is in the slide deck. So we appreciate your time. I'm going to just ask Keith to come up and say goodbye as well, and look forward to seeing everybody in November virtually.
Thanks, Michelle. I don't have a lot to add, but thank you for your attention as always. And please give us feedback. We are experimenting here with a virtual format. To be honest, first time I've really probably been talked into a camera like this. So help us do better with the next one. Which, just a reminder of the calendar of events. Couple committee meetings coming up in September. We will circle back about launching the disparities work group. And we will have another virtual meeting on November 6th. And we also have another awesome guest speaker here, Simon Mahler, who will be talking about the hard pathway, really one of the developers of that for implementation in the emergency department. Okay, so we're going to sign off now. We wish we could see you in person, but we know you're there with us as well. Bye.